Hello, my name is Naval Daver. I am an associate professor in the Department of Leukemia at the MD Anderson Cancer Center in Houston, Texas. Today, I will be providing an update on gilteritinib therapy in patients with acute myeloid leukemia. Gilteritinib is a FLT3 inhibitor. This is a very specific and highly potent drug that was US FDA approved for the treatment of patients with relapsed refractory FLT3 mutated acute myeloid leukemia, including those who have an ITD mutation or TKD mutation. The approval of gilteritinib in the relapsed refractory FLT3 mutated AML was based on a phase 3 multinational randomized study of gilteritinib versus investigator-choice chemotherapy. This was called the ADMIRAL study. The study had about 370 patients, and this was a 2:1 randomization for gilteritinib versus investigator-choice chemotherapy. Now, it's important to note that the investigator-choice chemotherapy could include either high-dose chemotherapy approaches, such as FLAG-IDA or MEC, which is mitoxantrone etoposide cytarabine, or a choice of lower-intensity therapies, such as low-dose cytarabine or azacitidine. And the investigator had to decide before randomization if they would be choosing a high dose or a lower intensity therapy. The phase 3 study had two key primary endpoints. One was response, which was measured by CR and CRH, which is CR with partial hematological recovery, and the second was overall survival between the two arms. And the gilteritinib showed a positive outcome for both of the primary endpoints independently. The CR/CRH rate was 34% versus 15% in favor of gilteritinib, so more than double with a significant p-value. And the median overall survival was 9.3 months versus 5.6 months in favor of gilteritinib. So this study very clearly showed that the single agent oral highly selective potent FLT3 inhibitor gilteritinib was able to improve both responses and survival compared with chemotherapy. Now, it's important to note that a majority of the patients, about 75 to 80% of patients who went to chemotherapy actually went to high-dose chemotherapy. So this makes the data even more striking because what we're saying is an oral targeted, potentially outpatient regimen, which is very well tolerated, was actually superior to three-drug chemotherapy like FLAG-IDA or MEC. And that's pretty much a major shift and game changer for targeted therapies in AML. So what are the next steps now? We know gilteritinib is approved. It is being used very extensively in the United States as well as in Europe in relapsed refractory FLT3 ITD and TKD AML. But I think it's important to point out that when you look at long-term survival, 1 and 2 year survival, these are about 35 and 15, 20%. So at 2 years, we're still having a very small proportion, only 15% or so alive. And these are mainly patients who are able to go quickly into transplant once they achieve remission with gilteritinib. So I think the approval of gilteritinib is the first step in improving the outcomes for relapsed FLT3 mutated AML. And the next steps that hopefully will push this field forward are combinations. We are doing a number of studies combining gilteritinib with other agents. One of these is a combination of gilteritinib and venetoclax based on very potent preclinical synergy and synthetic lethality for these drugs. This was presented at the ASH meeting by my colleague, Dr. Pearl, in 2019, and we will be updating it in 2020. And we are seeing, based on the data shown in ASH 2019, almost 80% CRC marrow remission rates, which is almost double of the 50% or so that we get with gilteritinib alone, and the durability seems to be good. So we feel that this combination, which is based on the biology of FLT3 resistance and escape, is showing very good activity and hopefully will further improve not only remission, but duration of response and long-term survival. The other combinations that are being looked at are with gilteritinib in the frontline setting. Both of these are actually randomized phase 3 studies for additional approvals of gilteritinib with either 3+7 induction gilteritinib versus 3+7 midostaurin, which is the current induction standard for a FLT3 mutated new AML. And the second is the azacitidine with gilteritinib versus azacitidine. So we're hoping in the next 1.5 to 2 years, we have data from both of these. And with these combinations, and actually we also now have a triplet of azacitidine, gilteritinib, venetoclax, which we think could be really a major improvement. So we feel that the FLT3 mutated AML, both frontline and relapse, have a very powerful outcome and hope for the future. In addition, there are other FLT3 inhibitors that I won't go into detail, but these are also very potent and exciting: quizartinib, crenolanib, and older ones that have already been approved, like midostaurin, and have been used commonly, like sorafenib. So I think the future in the next 3 to 5 years with optimal combination sequencing of these FLT3 inhibitors, selecting the best one based on the total molecular and mutational profile of patients will really hopefully improve the outcomes dramatically, improving the long-term cure rates. And the FLT3 field has really progressed dramatically in the last 10 years and hopefully will continue to do so in the next decade. Thank you very much.